Now we move on to adynamic bowel obstruction. And in adynamic bowel obstruction, the first condition which we will talk about. So adynamic bowel obstruction is when there is no physical obstruction to the flow of feces. And the first condition which we'll talk about is congenital megacolon or Hirschsprung's disease. So congenital megacolon or Hirschsprung's disease, this is a type of a neurocrystopathy. That means there is loss of ganglion cells. In both Orbach and the Meissner's plexus of variable portions of rectum and colon, right? So these ganglion cells are missing from variable portions of the rectum and colon, and that is why proper peristalsis is not occurring, and we call it a neurocrystopathy because it is because of these ganglion cells arise from the neural crest. So it's basically a neural crest defect. That is why we call it a neurocrystopathy. This is common in Down syndrome, commonly seen associated with Down syndrome patients, and it can also be seen in MEN2A syndrome more commonly as compared to MEN2B syndrome. So more commonly in MEN2A as compared to MEN2B. These are the associations of Hirschsprung's disease. Another thing which is implicated is the glial-derived neurotropic factor, GDNF. Glial-derived neurotropic factor is implicated in patients with Hirschsprung's disease. Now, Hirschsprung's disease, the most commonly affected is the rectum, and then colon can be affected. The clinical features, so it can either have an acute presentation, and the acute presentation will be seen in a newborn itself, and the most common thing is failure of passage of meconium. Right? So this was a very common call when we were doing a peripheral posting in pediatric surgery. A very common call used to come from the gynae resident, and she used to say that we have a child who has abdominal distension. The child has abdominal distension, and since birth the child has not passed meconium. So you can see here distension, massive distension is going to be there, and the child will not pass meconium. And when you used to go with the pediatric surgery resident to the pediatrics ward, and when we do a PR of this child, if you do a PR or a digital rectal examination, then meconium is passed. So that leads to stimulation, and meconium passed immediately after doing a DRE or a per rectal examination, right? So this is the acute presentation or the classical presentation. Some patients can have a late presentation as well. Late presentation will either be in the form of failure to thrive. The child will not gain weight, or there can be chronic constipation, in these children. So these are the various features or the clinical presentations of Hirschsprung's disease. Now, how do we confirm the diagnosis? So how do we confirm the diagnosis? The investigation of choice is a full thickness rectal biopsy. This has been asked many times in the exam, so I've already told you the clinical features, and when you're suspecting this, you will do a full thickness rectal biopsy. And the the histopathological features which you see on a full thickness rectal biopsy are going to be loss of ganglion cells. There's going to be loss of ganglion cells. There will be hypertrophied nerve trunks. There will be hypertrophied nerve trunks. And immunohistochemistry, IHC, for acetylcholinesterase. Immunohistochemistry for acetylcholinesterase. So this is what you will get on histopathology on a slide when you do a full thickness rectal biopsy. Now, once we've made the diagnosis, now I need to see what is the extent of the disease. So before I take up the patient for surgery, a rough indicator of the extent I can get to know by a contrast enema. A rough indicator of the extent I can get to know from a contrast enema. And why am I saying a rough indicator? Because the accurate place to know which bowel portion has ganglion cells or does not have ganglion cells can only be determined during surgery. And I will tell you how do we determine during surgery. But a rough indicator we will get when we do this contrast enema. You will get a dilated bowel. This is the dilated portion. You will get a transitional zone. This is the transitional zone. And you will get constricted bowel. And you will get constricted bowel. So traditionally speaking, it is the dilated bowel which has normal ganglion cells. It is the normal bowel which has it is the dilated bowel which has the normal ganglion cells. So this gives us a rough estimate. Now the management of these patients, we have to carry out surgery, and the surgery can either be a single stage surgery, or it can be a two-stage procedure. In the two-stage procedure, the first stage is a colostomy if bowel is distended, if massive bowel distension is there. If massive bowel distension is present, then the first stage is to do a colostomy, let the bowel come back to a normal size, and then we do a second definitive procedure. Otherwise, we can do the definitive procedure in a single stage. And what are the principles of definitive surgery? The principles of definitive surgery are either resect the abnormal portion, or we bypass the abnormal portion. Either resect the abnormal portion or we bypass the abnormal portion. Those are the two principles which you need to know. And during surgery, we take a frozen section from the margin. So whatever bowel you're resecting, you will take a frozen section from the margin, and this is what is going to determine, and this is taken to determine if ganglion cells are present or not. So this is the best way to determine what is the extent, and if the margin has ganglion cells, then we can safely carry out the anastomosis. There are three names which you can remember. You have Swenson, you have Soave, and you have Duhamel procedure. Swenson, Soave and Duhamel procedures, you can just remember the names. These are the surgeries which are done for Hirschsprung's disease. This was the first condition of adynamic bowel obstruction which we have discussed. The second condition which we need to talk about is mesenteric ischemia. And mesenteric ischemia was asked in this year's INI CET exam as well. So a very important topic which you should know about. Now mesenteric ischemia, the first division of mesenteric ischemia can either be into arterial or it can be venous. So arterial is the main one, but let's just finish venous and then we'll move on to arterial. This is MVT, mesenteric venous thrombosis. This is mesenteric venous thrombosis. Now, mesenteric venous thrombosis occurs secondary to Virchow's triad. Virchow's triad we have already discussed in DVT. You know, Virchow's triad is stasis, hypercoagulable state, or endothelial injury. So the same predisposing factors can give rise to a mesenteric venous thrombosis as well. And this mesenteric venous thrombosis usually involves the superior mesenteric vein, and the clinical features, it can give rise to bowel ischemia. It can give rise to bowel ischemia, and you can get gangrenous bowel when you open up this patient. The investigation of choice is a CT angiography. The management is anticoagulation. Like it was the case in DVT. We give papaverine. Papaverine is a vasodilator. And if bowel gangrene is present, we resect that bowel. Then you need to resect that portion of bowel. Arterial causes can either be NOMI or you can get occlusive mesenteric ischemia. Occlusive MI, that is mesenteric ischemia. NOMI is non-occlusive mesenteric ischemia. So non-occlusive mesenteric ischemia is seen in patients with congestive heart failure. Okay. So understand a situation that, you know, in most of the houses or societies, there is a pump which is there, and this pump pushes water from the ground level to a higher level into the tanks. Now, if one day, if the electricity is not coming, the pump will not work. Now, if the pump does not work, water is not going to go from the ground level to the tank, even when there is no obstruction in the pipe. There's no obstruction in the pipe, but there's not enough pressure for water to go up from the ground level to the tank. Similarly, in non-occlusive mesenteric ischemia, there is no occlusion in the vessels, but blood cannot go through to the bowel because of congestive heart failure. The heart is unable to generate that much, is unable to generate pressure. So this is usually seen in the ICU settings, and the management is to give inotropes to the patient, is to correct the CHF, and that is how we can ensure that blood reaches to the bowel. Now the main is occlusive mesenteric ischemia. This is the one from which maximum questions have been asked, and occlusive mesenteric ischemia can be divided into two. Now occlusive mesenteric ischemia, you can either have AMAE or you can have AMAT. AMAE is acute mesenteric artery embolism. And AMAT is acute mesenteric artery thrombosis. You need to know that acute mesenteric artery embolism is more common than acute mesenteric artery thrombosis. In fact, acute mesenteric artery embolism is the most common cause of mesenteric ischemia, and this was the statement which was asked in this year's INI-CET exam as well. And what will be the predisposing factors for this embolism? So the predisposing factors will be a patient who has an atrial fibrillation. If the patient has atrial fibrillation, then from the heart, you can have heart as the most common source of this embolism, usually seen in patients with atrial fibrillation. This will be the key word which you would be looking in the clinical STEM to make this diagnosis. Or it can be an aneurysm, rarely, which can throw out an embolism. Now, the clinical features This is usually involving the superior mesenteric artery. It usually involves the superior mesenteric artery, and the clinical features, patient is going to come with a bowel attack. Patient is going to come with a bowel attack. Right, bowel attack, like a heart attack, you have sudden abdominal pain. You have sudden abdominal pain which is going to occur, and ultimately this pain is going to end with peritonitis. It is going to end with peritonitis. Now, one thing which I want you to remember, that sometimes when you have peritonitis in elderly patients, right, elderly patients might not show signs of guarding, rigidity, rebound tenderness. So this you should remember. Sometimes in the clinical question they can confuse you, that they can give you a statement where there's an elderly patient and they'll say that the abdomen is still soft. That's because elderly patients, sometimes these signs might be missing. So don't get misled by that statement. So this is sudden abdominal pain which ends with peritonitis. The investigation of choice is a CT angiography. That is going to clinch the diagnosis for us. And the management for acute mesenteric artery embolism, if the patient presents early, that is within 6 to 8 hours, there is no peritonitis, then in these patients we will carry out an embolectomy. If you remember the module on arterial disorders, I've already told you embolectomy is done using Fogarty's balloons or Fogarty's catheters. So you can look at the image of Fogarty's balloons or Fogarty's catheters in the arterial module where I've covered this in detail. If the patient presents late, that is after 6 to 8 hours, or there is peritonitis which is present, then in these patients we need to carry out surgery and we need to resect gangrenous bowel. Now if you remember your anatomy, you know that the superior mesenteric artery is supplying from the duodenum, from part of the duodenum till mid of the transverse colon, right? That is the supply of the superior mesenteric artery. Now, if the superior mesenteric artery gets blocked, you know that such a large portion or variable portion of bowel can get gangrenous. And if you resect this much gangrenous bowel, there is a high chance of short bowel syndrome developing. I've covered short bowel syndrome in detail, and I've also told you that superior mesenteric artery embolism is one of the leading causes of short bowel syndrome. So this was regarding superior mesenteric artery embolism. On the other hand, you have acute mesenteric artery thrombosis. Now, acute mesenteric artery thrombosis will be seen in elderly patients. It is secondary to atherosclerosis. And this also involves the superior mesenteric artery is involved commonly. So the clinical features of acute mesenteric artery thrombosis or mesenteric artery thrombosis, that the patient is going to come with bowel angina, right? Like you know, anginal pain, heart pain, if somebody exercises or eats a heavy meal, then the anginal pain can get precipitated. Similarly, bowel angina is that this is the aorta, this is the superior mesenteric artery. Now, whenever the patient has food, we want more blood to flow in, right? So that, you know, it can help in the digestion and the absorption of food, which is why if you have a heavy meal and all the blood is getting diverted here, which is why we feel drowsy after a heavy meal and we can't study at that time. But anyways, when you have food, we want more blood to flow into the bowel. But if there is an obstruction here, if there is a thrombus here, then blood cannot flow. So the clinical features are going to be that there is going to be postprandial abdominal pain. There will be postprandial abdominal pain. This usually starts 10 minutes, usually starts 10 to 15 minutes after meal, and it can go on for 1.5 to 2 hours. And it can persist for 1.5 to 2 hours, right, this pain. And once this pain settles down, the patient thinks, well, let me have more food now, I'm feeling hungry again. Again, when the patient has food, again the patient is going to have pain. So a couple of times the patient has this pain, and then he realizes that food is the cause of his pain. So the patient will gradually become scared of food. Patient will stop having food. And if the patient becomes scared of food, there is going to be weight loss. So weight loss, patient not feeling hungry, and abdominal pain, these features can also be seen in a cancer or malignancy. So that is one of the differential diagnoses of mesenteric artery thrombosis, that is a malignancy. Okay. The investigation of choice to confirm this is a CT angiography, and the management of these patients is a bypass grafting. We need to bypass the thrombotic segment by doing a bypass grafting. And we can use a Dacron graft to bypass the segment. This I've covered in the arterial module. So this was regarding mesenteric ischemia. This is an important topic for your Central Institute exams. Another thing which you should know before I end this topic of mesenteric ischemia is that if you do an X-ray and if there is bowel ischemia, then you can get a thumb printing sign. You can get a thumb printing sign when there is bowel ischemia. And it is caused by submucosal infiltration of air. This is going to cause this thumb printing sign. This is a sign of bowel ischemia on an X-ray. This is something which you should know about. So another cause of adynamic bowel obstruction, and this is quite common, is paralytic ileus. Now, as the name suggests, this paralytic ileus is due to failure of bowel to contract. And this occurs due to failure of neuromuscular transmission. Now, what are the various causes which can give rise to paralytic ileus? So, the causes of paralytic ileus, this can either be post-operative, and post-operative paralytic ileus would depend on the amount of bowel handling, done during surgery. So, for example, if I am doing a mastectomy and the patient has got general anesthesia, there is some amount of ileus which is still going to occur. But because I haven't handled the bowel is going to regain motility within a few hours. So I start my patients orally in 3.5 to 4 hours. But if I've done an abdominal surgery where I've handled the bowel, then of course the bowel is going to remain stunned for a longer period and it will take a longer time to recover. If an anastomosis has been done or not, it also depends on that. If an anastomosis has been done, it will take more time. It also depends on the extent of surgery. The extent or the duration of surgery. Longer the duration, the longer can be the ileus. Other causes of ileus can be dyselectrolemia. And very important here is hypokalemia. In fact, hypokalemia, this has been asked in multiple exams, is the most common cause of prolonged paralytic ileus. Most common cause of prolonged ileus, right? And I'll just tell you a story here. This actually happens in the surgery ward. So, whenever a resident does an anastomosis, he's so worried that the anastomosis doesn't leak. So every day in the morning, he'll come and straight away go to that patient and he'll ask the patient, have you passed flatus? Have you passed feces? And if the patient says, or the sound of flatus for that resident is like music to his ears, but the patient keeps on saying, no bowel movement, no flatus. The resident keeps his stethoscope and tries to listen to the bowel sounds. No bowel sounds. Now the resident gets worried. But the intern who's sending out all the blood reports usually comes and tells the resident that, sir, this patient has hypokalemia, and that might be responsible for the prolonged ileus. So it is one of the commonest causes of prolonged ileus, and one should always look out for this. Another cause of prolonged ileus is uremia. Increased blood urea can also give rise to ileus. Hypothermia is another cause which can predispose to prolonged paralytic ileus. Now, a patient with paralytic ileus, the clinical features of a patient with paralytic ileus would be abdominal distension, right? Non-passage of flatus and feces, but there is no pain usually. There is no pain here. These patients will usually not have pain. And we know that the initial investigation in these patients is an X-ray abdomen. Now, when we do an X-ray abdomen in these patients, you can see that in this X-ray abdomen, you can see that gas is reaching till the rectum. Right? So that means there is no physical obstruction. Gas is reaching right up till the rectum. But you can see that the bowel is distended. So this is the X-ray which you get in a patient with paralytic ileus. If it is prolonged ileus, which is not getting fine, we can do a CECT to rule out dynamic obstruction. In these patients, right? And the management of paralytic ileus would be correction of the electrolyte abnormalities. If it is prolonged ileus, that means it is persisting for more than 4 to 5 days. If it is prolonged ileus, then TPN, total parenteral nutrition, can be given to maintain the nutrition of the patient. You need to know that it is the jejunum or the small intestine which regains motility first. Colon is the last to recover. And another point which you should know, that the pacemaker of the bowel is present in the fundus of the stomach. So these are the points regarding paralytic ileus. You also need to know last to recover is colon. This has also been asked in the exam. Now, another type of paralytic ileus is colonic pseudo-obstruction. Now, colonic pseudo-obstruction is nothing but ileus in the colon. This is ileus in the colon, right? And this can either be primary colonic pseudo-obstruction, which is without any predisposing factors, is known as Ogilvie's syndrome, or it can be secondary to neurological conditions. Like Alzheimer's, Parkinson's. It can be seen post-spinal injury. It can be seen if there is a retroperitoneal hematoma. And let's try to correlate. If you remember, in the kidney module, I spoke about renal injury. And in renal injury, there is a retroperitoneal hematoma. And I told you on day 3, day 4, the colon can get distended. And that happens because this hematoma presses on the splanchnic nerves. And that can give rise to colonic distension. And the term I used there was meteorism, right? So retroperitoneal hematoma can give rise to colonic distension by meteorism or Ogilvie's syndrome. This can even be seen in patients with hypothyroidism. right? Now the clinical features again are going to be abdominal distension. Patient is going to have abdominal distension, and abdominal distension in colonic obstruction is massive abdominal distension is going to be there, and there is going to be non-passage of flatus and feces. There's going to be non-passage of flatus and feces. Now if we do an X-ray, we know that the colon is getting distended. So I have told you that if cecum is more than equal to 9 centimeters in diameter, this is the critical diameter when the cecum can perforate. So if the cecum is dilating, is progressively increasing in size, we should take quick action, otherwise there can be a cecal perforation. In these patients, a CECT should be done to rule out dynamic obstruction. Now, what is the mechanism? Because if we understand the mechanism, then we'll understand the treatment of Ogilvie's or colonic pseudo obstruction. So here what happens, there is sympathetic overactivity, because of which there is impaired peristalsis. There is sympathetic overactivity because of which there is impaired peristalsis in these patients, and that gives rise to colonic distension. So the management of these patients, rule out dynamic obstruction, and once dynamic obstruction has been ruled out, we give IV neostigmine. And this giving of IV neostigmine, this is known as the catch-pole regime. This is catch-pole regime. And when you give this IV neostigmine, within minutes, patient passes stools and flatus. Right? Within minutes, patient passes stools or flatus. If this also does not work, then you carry out a colonoscopic decompression so that the cecum does not perforate. So that is the management of Ogilvie's or colonic pseudo-obstruction, and that was the last cause of adynamic obstruction which you need to know about, right? So we've discussed dynamic, adynamic obstruction causes in detail. At least one question or two questions from bowel obstruction are asked in the MCQ exam, so it's a very, very important module. Again, let's do some MCQs and then I'll highlight the important topics for the final year students. You have an X-ray after abdominal surgery shown below. Patient is in a state of ileus. That means the bowel sounds are not there. What is the most common cause of paralytic ileus? Prolonged paralytic ileus, I've already highlighted it, is hypokalemia. Bowel obstruction, true and false. Initial investigation in adults is CECT. This is false. Initial investigation is X-ray abdomen, erect and supine. Investigation of choice in children is ultrasound. This is true. For adults, it is CECT. Initial management should be nasogastric tube placement and IV fluids. This is true. If surgery is done, first structure which should be visualized is the terminal ileum. This is false. It should be the cecum. I've highlighted this. Let's match the signs to the clinical condition. Claw or pincer sign. This can be seen in intussusception. Double bubble sign can be seen in duodenal atresia. Triple bubble, I've highlighted, is seen in jejunal atresia. Coffee bean sign is seen in sigmoid volvulus. Sawtooth appearance is seen in diverticulosis. This has been highlighted in the benign small and large bowel conditions module. And apple core deformity can be seen in colonic cancer. This is for left-sided lesions. Intussusception, colocolic is the most common type overall. This is false. It is ileocolic. Ileocolic is most common. Ileocolic is most common in adults. This is false. In adults, it is colocolic. In children, it is ileocolic. Overall, most common is ileocolic. Hypertrophy of Peyer's patches is the most common trigger. True. Polyps are the most common pathological lead points. This is also true. Ischemia most commonly occurs at the neck of intussusception. This I told you is false. I told you neck is the narrowest portion, but ischemia is going to occur first at the apex. First and most commonly at the apex. Red currant jelly stools can be seen in children with intussusception. This is true, and I forgot to cover this in the, I think so I forgot to mention this when I was talking about the clinical features of intussusception. So these are two things which you should definitely know in intussusception in children. When you get intussusception in children, one sign which you can get is a sign of dance, which you can see, and the other one are red currant jelly stools, So sign of dance is when you palpate the abdomen of a child with intussusception. When you palpate the abdomen of a child with intussusception, the right iliac fossa is empty. Now, if you assume it's ileocolic, ideally the lump should be in the right iliac fossa, but the right iliac fossa is empty, and you get a sausage-shaped lump. In right lumbar region. So the lump dances its way from the iliac fossa to the lumbar region. This is sign of dance. Please add this to your notes of intussusception. And red currant jelly stools is blood mixed with mucus. Red currant jelly stools is blood mixed with mucus. Sometimes mothers confuse it for stools, but there are no actual fecal content. It is just blood mixed with mucus. This can also be seen in children with intussusception. So please add these 2 points to your notes on intussusception. Contrast enema is indicated with perforation and strangulation. This is false. In this case, you need to carry out surgery. All of the following are true regarding Meckel's diverticulum. Bleeding is the most common presentation in children. This is true. Obstruction is the most common presentation in adults. This is also true. True diverticulum along the antemesenteric border. This is also true. Obstruction is usually due to a volvulus around the band. This is false. The most common cause of obstruction is intussusception. So this was regarding bowel obstruction. For final year students, this is a very important module. You can get short notes on Meckel's, very important, on volvulus, on intussusception, on atresias. These are the common short notes which are asked from this module. Sometimes a clinical scenario is given and a long question is asked. So you should all know about this module. And if you have any further queries or you want to ask me any clinical question, you can either ask me a question on the Marrowlinks Facebook group. Just send a request there, we'll add you to that group, or you can send me a message on my Instagram handle and I'll answer that. That is left-handed surgeon. Thank you.